path for that pressurized pus to burst into is backward, directly into the brain.
Oh, no.
You cannot spend 3 hours doing a delicate draft third procedure. You take a scalpel, make a small cut just under the medial edge of the eyebrow, take a surgical drill, punch a hole straight through the front of the skull into the sinus, and place a plastic drain tube. It is crude, it is fast, and it instantly depressurizes the skull and saves the patient's life.
Which perfectly sets the stage for the most intense part of these protocols. Because when you're using high-speed drills and sharp instruments millimeters away from the brain and the eyes, well, things will eventually go wrong. Let's enter the danger zone.
Oh man, every surgical resident reads this section of the manual until the pages are worn out. This is what keeps an ENT surgeon awake at 3 a.m.
I bet. The protocols break down the statistical reality of surgical disasters. They categorize minor complications as happening in about 2 to 3% of procedures. This includes things like orbital emphysema, ecchymosis, and NLD lacrimal duct injury.
Minor complications are usually inconvenient but highly reversible. Orbital emphysema happens when the paper-thin wall is cracked and the patient blows their nose, forcing air into the eye socket.
That sounds weird.
The eye puffs up, but the body absorbs the air in a few days. Ecchymosis is just a severe black eye, and the NLD is your tear duct. If the surgeon accidentally grazes it, the duct might scar shut, causing watery eyes that require a minor procedure to reopen later.
But then we reach the major complications. The texts assign a 1% occurrence rate to these, 1 in every 100 surgeries, and the list is absolutely chilling. Hemorrhage, cerebrospinal fluid leak, orbital hematoma, optic nerve injury.
Yeah, 1% sounds low to a patient signing a consent form, but to a surgeon performing 400 cases a year, it means that 4 times a year they are going to face a life-altering emergency in the OR. They don't have time to look up the protocol, it must be muscle memory.
And the protocols for these emergencies are visceral. Like, the most dramatic one detailed is the response to an intraorbital hemorrhage.
This is an incredibly tense, stop the room every second count scenario.
Walk me through the mechanics of this. A surgeon is operating in the ethmoid sinus right next to that lamina papyracea. They slip, or a piece of bone shifts, and they sever one of the arteries inside the actual eye socket. Blood starts pumping into the space behind the eyeball. What is physically happening?
Well, you have to look at the geometry of the orbit. The eye socket is a rigid bony cone. The eyeball is sitting in the open end.
Okay.
When an artery is cut inside that enclosed cone, arterial blood starts pumping in at high pressure. But the space is fixed. The blood has nowhere to go. So the internal pressure skyrockets, and it forces the path of least resistance. It pushes the eyeball itself out of the socket.
Which is what the notes call proptosis.
Right, exactly. That bulging is proptosis.
But the bulging eye isn't the real danger, it's the pressure behind it.
Exactly. The optic nerve, the biological fiber optic cable that sends visual data from your eye to your brain, runs right through the middle of that socket. And that nerve requires a constant supply of highly oxygenated blood from tiny, delicate capillaries.
Right.
When the pressure in the eye socket hits around 90 millimeters of mercury, it forcefully crushes those tiny capillaries flat. The blood supply to the optic nerve is completely cut off.
So the nerve starts to suffocate.
It suffocates rapidly. The protocols dictate checking for a loss of pupillary reflex. If the surgical team shines a bright light into the bulging eye and the pupil stays fixed and dilated instead of shrinking down, it means the optic nerve is dying.
That's terrifying.
The brain is no longer receiving the signal. The surgeon has between 60 and 90 minutes before that nerve death becomes permanent, and the patient is completely, irreversibly blind in that eye.
And the physical maneuver required to stop this is, I was honestly shocked reading it. You have an internal pressure of 90 millimilli Hg. Normal eye pressure is around 14 to 17. To save the eye, the protocol mandates an immediate lateral canthotomy and cantholysis.
It is one of the most aggressive, barbaric sounding maneuvers in modern medicine, but it is purely driven by physics.
You literally take surgical scissors and snip the tendons at the outer corner of the patient's eyelids.
Yeah, so think of the eyelids and their attached tendons as a tight drumhead stretched over the front of the eye socket, locking the eyeball in place.
Okay.
The pressure is building up behind the drumhead. By taking heavy scissors, crushing the skin at the outer corner of the eye, which is the canthotomy, and then physically snipping the inferior and superior bands of the lateral cantholysis and the cantholysis, you sever the drumhead, you completely release the tension holding the eye in.
The eyeball just springs forward.
It literally prolapses forward. The volume of the socket instantly expands, the pressure violently drops from 90 back down to 14, the capillaries reopen, and blood rushes back to the optic nerve. You detach the eyelid from the skull to save the sight.
The psychological pivot required for a surgeon to do that is unfathomable to me. Like, 1 second you were doing millimeter precise endoscopic micro movements, and the next second you were rapidly cutting a patient's face with scissors.
It demands total emotional detachment in the moment. You cannot freeze.
But amazingly, that is not the ultimate nightmare scenario of detail here. That distinction is reserved for the carotid artery injury.
Oh, the internal carotid artery is one of the massive pipes carrying the vast majority of the blood supply directly to the brain. It runs right alongside the sphenoid sinus.
Okay.
In a small, unlucky percentage of the population, the thin bone separating the sinus from the carotid artery naturally deteriorates.
Leaving the arteries pulsing there, completely bare in the surgical field, like an exposed high voltage wire.
Precisely. Now imagine accidentally grazing that exposed, pressurized pipe with a sharp surgical instrument.
Let's use the plumbing analogy. It's like accidentally swinging a pickaxe into the main pressurized water line in your basement. But the basement is pitch black, the water is flooding to the ceiling instantly, and you can't reach the shutoff valve. The protocol here is just 3 staccato sentences: pack sphenoid immediately, resuscitation by anesthesia, endovascular stent by interventional radiologist.
Notice exactly what the protocol doesn't say. It doesn't say find the hole and sew it up.
Why not?
You can't. The internal carotid is pumping nearly a liter of blood a minute. A blowout in the sphenoid sinus will instantly fill the endoscopic camera view with pure opaque red. The patient will exsanguinate, bleed to death on the table in a matter of minutes.
So what does pack the sphenoid actually mean in that moment?
The surgeon's only job is to furiously shove yards of gauze, packing, muscle tissue, whatever sterile material they have, directly into the sphenoid sinus, packing it as tightly as physically possible against the hole in the artery to create a massive pressure tamponade.
Just plug the leak.
Exactly. They are physically holding back the blood pressure of the heart. Meanwhile, they scream for the anesthesia team to start pushing massive volumes of blood transfusions to keep the brain alive.
And what about the endovascular stent?
Because the ENT surgeon can't fix it from the outside, they have to call in an interventional radiologist. While the ENT is holding pressure in the nose, the radiologist makes an incision in the patient's groin, threads a catheter all the way up the femoral artery, into the aorta, up the neck, and deploys a metal mesh stent from inside the carotid artery to patch the hole from within. It is a massive multi-team fight against the clock.
Unbelievable. The final major complication listed is the CSF leak, cerebrospinal fluid. This means the surgeon has reached that phobia, as Wendel's we talked about earlier. They went through the ceiling and entered the brain cavity. The protocol is simply immediate repair.
Yeah, your brain floats in a sterile bath of cerebrospinal fluid. If you punch a hole in the floor of the brain, that fluid starts dripping down into the nose. It looks like clear water.
Which doesn't sound as bad as a liter of blood a minute, honestly.
Well, the immediate danger isn't losing fluid, it's what can go the other way. You have just created a direct, open highway from the bacteria-rich nasal cavity straight into the sterile brain.
Oh, meningitis.
Exactly. Severe, rapid onset, potentially fatal meningitis. If a surgeon recognizes that clear fluid leaking, they cannot wake the patient up. They must instantly transition to a repair, harvesting a piece of the patient's own tissue or bone to plug the hole and seal the brain vault shut again.
So hearing all of this, a very reasonable listener might be asking themselves a fundamental question right now. If this surgery is so inherently dangerous, if the risk of brain fluid leaks, blindness, and catastrophic arterial blowouts is a constant reality, why do it? Why not just live with a bad sinus infection?
That is the crucial pivot, and the answer is found by looking at the fallout of disease. Surgery is dangerous, yes. But leaving severe progressive sinus disease untreated leads to anatomical destruction and horrifying complications of its own. The disease itself will execute the demolition if the surgeon doesn't intervene.
The protocols break down these natural complications into two major anatomical pathways: intracranial, so the brain, and orbital, the eye. Let's start with the brain.
Okay, so as we established, the sinuses in the brain share a common wall. If a severe bacterial infection gets trapped inside a locked sinus cavity, the bacteria multiply, producing massive amounts of pus and gas.
And the pressure builds.
Exactly. Eventually, that pressurized infection will find a way out. It will either eat directly through the bone, or it will travel backward along the tiny veins that connect the nasal cavity to the brain lining.
The text states that a subdural emphysema is the most common intracranial complication of severe sinusitis. What is the mechanism there?
Your brain is shrink-wrapped in protective layers called meninges. The outermost toughest layer is the dura mater, literally tough mother in Latin.
Great name.
Right. A subdural empyema occurs when the sinus infection reaches the bone and pools underneath the dura mater directly on top of the soft folded tissue of the brain. It forms a massive pocket of highly pressurized pus.
And because the skull can't expand, that pus pocket starts crushing the brain tissue.
Exactly. It presses on the motor cortex, the speech centers. It causes massive, rapidly progressing neurological deficits, severe seizures, and profound lethargy.
How do you fix that?
It requires an immediate neurosurgical craniotomy, removing a piece of the skull to drain the pus and relieve the pressure.
Wow. The list of brain complications continues. Extradural abscesses, meningitis, and a condition called cavernous sinus thrombosis, or CST.
This is one of the most feared natural complications. The cavernous sinus isn't a sinus in the way your nose has sinuses. It's not filled with air.
What is it then?
It is a massive pool of venous blood situated right at the base of your brain, directly behind your eyes.
Why is it so dangerous if an infection reaches it?
Because of the wiring that runs through it. The major cranial nerves that control the movement of your eyeballs travel straight through the middle of this blood pool.
Okay.
If bacteria from your nose travel up the veins and infect this pool, the blood clots. That's the thrombosis. When it clots, the veins back up, your eyes violently bulge outward, and because those cranial nerves are paralyzed by the infection, your eyes completely freeze in place. The patient cannot move their eyes in any direction.
That is horrifying.
Historically, before modern antibiotics, CST was almost uniformly fatal.
Man. Then you have the orbital complications, the infection heading sideways instead of upwards. The protocols list a clear progression of severity: septal cellulitis, orbital cellulitis, and superior abscess.
Yeah, it's a literal march of the bacteria deeper into the eye socket. Septal cellulitis is just an infection of the eyelid skin. The eye itself is safe.
But if it reaches the orbital septum, it becomes orbital cellulitis.
Right.
The fat and muscles actually moving the eye become deeply infected,
Right.
and superior abscess.
So the periosteum is a tight membrane wrapping around the bones of the eye socket. An abscess here means a pressurized pocket of pus has formed between the bone and that membrane.
And it pushes the eyeball.
It physically pushes the eyeball out of the head and stretches the optic nerve. It causes the exact same blinding pressure cascade we talked about with the surgical hemorrhage, but caused by a rotting bacterial infection instead of bleeding.
And there is one specific condition highlighted here with a name that is so incredibly deceptive: Pott's puffy tumor. Honestly, it sounds faintly ridiculous, like something out of a children's cartoon.
The name is quaint, but the pathology is gruesome. It was first described by Sir Percival Pott, an 18th century English surgeon.
The text defines what it actually is in clinical terms: osteomyelitis in front of the bone.
Osteomyelitis means a deep, destructive bacterial infection inside the marrow of the bone itself.
How does a sinus infection melt your skull, though?
Well, if a severe infection in the frontal sinus is left untreated, the bacteria trigger your body's own osteoclasts, the cells responsible for breaking down bone tissue to go into overdrive.
Oh.
The bone of your forehead literally begins to rot and dissolve from the inside out. The infection reaches the front wall of the skull, and massive amounts of pus pool underneath the skin of your forehead, causing a large, doughy, puffy swelling. That puffy tumor on the forehead is a visible marker that the skull beneath it is disintegrating.
The treatment detailed for this is a monumental medical effort, like 6 to 8 weeks of continuous culture-directed intravenous antibiotics combined with surgical frontal sinus drainage.
Yeah, because bone marrow has notoriously poor blood flow, antibiotics struggle to reach the infection. You have to physically surgically wash out the dead, rotting bone, establish massive drainage into the nose, and then saturate the patient's entire systemic blood supply with antibiotics for months just to ensure the bone infection is totally eradicated.
To figure out exactly which complication a patient has, the protocols outline strict rules for medical imaging. You don't just guess, you image the hardware. CECT contrast-enhanced CT scans are listed as the investigation of choice, or IOC, for intraorbital complications.
A CT scan utilizes X-rays. Calcium tightly blocks X-rays.
Okay.
Because bone is made of calcium, a CT scan is the absolute best way to look at the skeletal architecture. If a bacterial infection is melting the paper-thin bone around the eye, the CT scan will show that destruction with crystal clarity.
But the protocols instantly switch gears if the brain is involved. For cranial complications, the IOC changes to SEMRI, contrast-enhanced MRI. Why the switch?
An MRI doesn't use X-rays. It uses massive magnets to resonate the water molecules in your body. Soft tissue like brain matter, pus, and dura mater is mostly water.
Ah, I see.
A CT scan is terrible at differentiating between different types of soft tissue, but an MRI will show you the exact microscopic boundary between a pocket of brain pus and healthy brain tissue.
And for that terrifying cavernous sinus thrombosis, they mandate an MR-venography.
Because you aren't looking at bone, and you aren't just looking at tissue, you need to see the active flow of blood through the veins. Venography highlights exactly where the massive clot is sitting in the skull base.
There's also a critical, inflexible timeline mentioned in the protocols regarding treating these complications, the 24-hour rule.
This is the physiological threshold. It dictates exactly when medical management ends and emergency surgery begins.
The rule dictates that if a patient comes in with eye swelling or early neurological signs, you start massive, broad-spectrum IV antibiotics and decongestants immediately. But if there is zero clinical improvement in exactly 24 hours, you bypass everything and go straight to the operating room.
You do not wait 48 hours to see if the drugs kick in. You don't wait a week. If you have been pumping a patient full of heavy IV antibiotics for an entire day and their eye is still frozen and bulging, it means the physical pressure of the abscess is so high that the blood carrying the antibiotics physically cannot penetrate the infection zone.
The drugs are basically useless.
Exactly. You have to take a knife and physically relieve the pressure immediately, or permanent tissue death will occur.
It is a stark, absolute line in the sand. But to give our listeners a breather, not everything in the world of ENT is about life-threatening brain infections or massive arterial blowouts. For our final section, we're going to step back from the brink of catastrophe.
Let's call this the plumbing and wiring section, the everyday structural mechanics of the nose.
Exactly. How surgeons patch the walls, adjust the radiators, and fix the leaky pipes. Let's start with the main structural wall of the house, the nasal septum.
The septum is the central pillar of cartilage and bone that divides your nose into left and right sides. It dictates the entire airflow dynamic.
The protocols detail a condition called septal perforations, literally a hole in the septum, categorized as small if they're under 2 centimeters and large if they're over 2 centimeters. Now, a naive question: it's just a hole between 2 air tubes. Why does a hole matter?
It matters deeply because of aerodynamics. Your nose is designed to pull air in smoothly laminar flow. When you punch a hole in the central divider, the air from the left nostril violently collides with the air from the right nostril. It creates massive turbulence.
Like 2 rivers slamming into each other.
Yes, and that turbulent airflow dries out the delicate mucous membranes incredibly fast. The tissue dies, forms massive painful crusts, bleeds constantly, and in many cases, as the air whips through the hole, it produces a very loud, high-pitched whistling sound every time the patient breathes.
That sounds maddening.
It is.
The treatments listed range from very simple engineering to complex reconstruction. On the simple end, they list surgical obturators, which are also called septal dummies.
This is the low-tech, highly effective fix. An obturator is a soft medical-grade silicone disc shaped like a tiny yo-yo. The surgeon literally just pops it into the hole.
Just like that.
Just pops it in. The 2 flanges of the yo-yo rest against the left and right sides of the septum, physically blocking the hole. It doesn't heal the tissue, but it instantly stops the turbulence, stops the crusting, and silences the whistling.
But for a permanent biological fix, the texts get incredibly complex. They talk about free grafts using fascia, bone, or cartilage to plug the hole. But the really fascinating one is the use of pedicled flaps, specifically a buccal mucosal flap. Buccal means cheek, right? They're using the inside of your cheek to fix your nose.
Yes. Rebuilding a hole is incredibly difficult because whatever patch you use needs a robust blood supply to survive. You can't just slap a piece of dead tissue on a hole and expect it to live.
Right.
So a surgeon will slice a thin layer of mucosal tissue from the inside of your upper lip or cheek, but, and this is the key of a pedicle flap, they don't cut it completely off.
They leave it attached.
They leave the base of the tissue securely attached to its original blood vessel. Then they tunnel that strip of living tissue up under the skin of the face into the nose and drape it over the hole in the septum. It acts as a living, bleeding patch until the nose heals around it.
That is insane plumbing right there. Tunneling cheek tissue into the nose. Moving outward from the central septum, the protocols tackle the sidewalls, the inferior turbinates.
The turbinates are the radiators of the nasal cavity. They are long, bony scrolls covered in thick, spongy tissue that expand and contract to warm, humidify, and filter the air you breathe.
But sometimes they get stuck in the expanded position. They become permanently swollen and block the airway. The protocol for fixing this is inferior turbinate reduction, and reading the options reveals a fascinating, ongoing philosophical debate within the surgical community.
It is the great divide in rhinology, mucosal preservation versus mucosal destruction.
Let's look at the preservation side first. The techniques listed include fracture, microdebrider, radiofrequency, and coblation. What is the overarching goal here?
The goal of preservation is to shrink the physical volume of the radiator without destroying the microscopic sweeping hair of the cilia that line the surface.
Okay.
If you destroy the surface mucosa, the nose loses its ability to humidify air and clear out mucus, leading to a miserable condition called empty nose syndrome. So you want to shrink the meat inside the turbinate while leaving the skin totally intact.
I want to highlight the microdebrider because the mechanism of this tool is amazing.
It is an elegant piece of engineering. A microdebrider is a tiny motorized spinning blade completely enclosed inside a hollow vacuum tube.
Right.
There's just a tiny window on the side of the tube exposing the blade. The surgeon makes a tiny nick in the front of the turbinate, tunnels this instrument under the mucosa, and turns it on. The vacuum sucks the swollen diseased tissue into the window. The blade instantly shaves it off, and it gets sucked away into a canister.
It's like liposuction for the nose.
Exactly. The surgeon hollows out the turbinate from the inside out, leaving the delicate outer lining perfectly untouched.
But then there's the other side of the philosophical divide, the mucosal destruction techniques. The protocols list superficial cautery, cryosurgery, and laser surgery.
These are the scorched earth methods.
You are literally burning or freezing the tissue.
Yes. You take a heated element or a laser and violently burn the outside surface of the turbinate. The body responds by creating thick, contracted scar tissue.
It shrinks it.
It is highly effective at shrinking the size of the airway blocker, but you permanently destroy that vital ciliated mucosal lining in the process. The field heavily leans toward preservation now, but these destruction techniques are still detailed because they are incredibly fast, require almost zero recovery time, and can be done in a clinic chair for patients who can't undergo major surgery.
And finally, speaking of clinical realities, we have to talk about the most common and sometimes most terrifying nasal emergency. Epistaxis, severe nosebleeds. We established the nose has an incredibly rich blood supply, pulling from multiple major arteries.
It has to, in order to rapidly warm freezing winter air to body temperature in a fraction of a second. The nose is a massive heat exchanger, but that means when a pipe bursts, it floods.
The protocols map out two major plumbing junctions where these blowouts occur. The first is right at the front of the septum, called Kieselbach's plexus.
This is the source of 90% of all nosebleeds. It's the classic childhood bleed.
And looking at the mapping, it's easy to see why. 4 separate arterial pipes converge right at this one spot. The anterior ethmoidal artery, the greater palatine artery, the septal branch of the sphenopalatine artery, and the superior labial artery.
It is an anatomical perfect storm. You have 4 pressurized pipes converging in the most exposed forward part of the nose. It's subjected to freezing dry air, it gets traumatized by fingernails, and it takes the brunt of any physical impact to the face.
But while the front nosebleed is messy, the deeper, darker junction is where the true emergencies happen. Woodruff's plexus, located deep in the back of the nasal cavity.
A posterior bleed is a completely different monster.
It's fed primarily by the sphenopalatine artery and the posterior pharyngeal artery. Why is a bleed here so much worse than a Kieselbach bleed?
Gravity and access. When Kieselbach bleeds, it drips out the front of your nose onto your shirt. You pinch your nostrils, and it stops. When Woodruff's plexus blows out, the blood doesn't come forward, it gushes straight down the back of your throat. The patient is swallowing massive volumes of blood, leading to severe nausea and airway compromise. It usually happens in elderly patients with severely high blood pressure, their arteries are stiff, and because it is so deep inside the skull, a doctor in the ER cannot simply pinch it or pack it easily.
When standard packing fails to stop a severe posterior bleed, the protocols detail surgical interventions. You have to go upstream and turn off the main water valve.
And you have 2 highly complex ways to do that.
The first is embolization of the internal maxillary artery.
This is usually performed by an interventional radiologist. They snake a long wire up from the groin, navigate through the arterial tree of the neck and face, find the specific branch feeding the nose, and inject a tiny coil or specialized glue to permanently plug the pipe from the inside.
The second option is direct surgical ligation, specifically targeting the sphenopalatine or the ethmoidal arteries. Ligation means tying it off.
Right. If the radiologist can't get there, the ENT surgeon goes in endoscopically. The nasal cavity is completely filled with rushing blood. The surgeon has to rapidly suction the blood, dissect away the tissue at the very back of the nose, find the sphenopalatine artery, which is roughly the diameter of a piece of spaghetti, and use a specialized tool to clamp a tiny titanium clip across it, shutting off the flow instantly.
Wow.
It is the ultimate display of calm anatomical mastery in the midst of total chaos.
And with that titanium clip, we have basically reached the end of these dense, intimidating surgical protocols.
We really have covered a staggering amount of biological real estate and clinical strategy.
We did. We started by mapping a 3D labyrinth so tight that millimeters mean the difference between sight and blindness. We explored the bizarre reality of trace zinc in the dental filling, acting as a catalyst for a massive fungal ball to invade the cheek. We unpacked the complex immunological warfare of macrolides and the ancient physics of Manuka honey.
We walked through the brutal, necessary architectural demolition of the draft procedures and confronted the visceral, high-stakes emergency protocols required when the pressurized pipes behind the face burst or the skull wall fails.
It completely changes how you view your own head. It isn't a solid block of protected bone. It is a deeply complex, incredibly delicate, highly pressurized system of air, blood, and paper-thin walls.
The margin of error is a fraction of a millimeter, but when the architecture holds and the plumbing functions, it is an absolute masterpiece of evolutionary engineering.
So as we wrap up this deep dive, I want to leave you with a provocative thought, something that stepped outside the surgical manual entirely. As you take your next breath through your nose, consider the evolutionary trade-off that built this dangerous labyrinth in the first place.
It's a fascinating question. Why would nature design us with such a fatal flaw? Why leave a paper-thin wall between our nasal bacteria and our brain?
Evolutionary biologists believe it comes down to a battle for real estate. Millions of years ago, the ancestors of humans began evolving massive, incredibly complex, energy-hungry brains. But skulls are heavy. To accommodate this massive new brain without making our heads too heavy for our necks to support, evolution had to hollow out the heavy bones of our face.
Wow.
It stole that dense structural real estate to create lightweight, air-filled crumple zones, our sinuses.
We quite literally sacrificed the armored protection of our respiratory tract to make room for higher intelligence.
Exactly. We traded thick, impenetrable facial bones for the ability to think, reason, and build surgical tools to fix the very flaws that evolution left behind. So the next time you get a stubborn sinus headache or feel pressure behind your eyes, remember that tiny, dangerous labyrinth. It's the architectural price you pay for having a big, beautiful human brain.
A perfect compromise.
The X-ray might not show the full complexity, but the maze is there. And now you know exactly what it takes to navigate it. Thanks for joining us on this deep dive.